PT for 15 years. Worked in a couple different settings. Been at shift for almost 3. It was 3 of us. It was pretty much, it was Lindsay, Darren, and then me there for a little while. And so we've grown quite a bit since then. And that's our team, and we've actually grown since then. So we have to keep taking updated pictures here. And soon, I can announce that, right? Soon we're going to expand to Cartersville. So if any of you guys are in Cartersville, we'll be over there as well. So that's where I live. So good for me, you know. So I'll be that way. Matt, what do you introduce yourself?
Matt Owen. I've been a therapist for over 20 years now, in various different locations, and I've been with Shift almost 2 years.
Yeah.
Because funny, we all come on Mount March for some reason.
Absolutely.
I know that's about the time we all start up, so everything's been going great. We just continue to grow, and that picture is going to be full soon.
Yeah, it is.
Completely.
So we do a lot of different workshops, and is this the first time we've done arthritis?
This is the first time we've done it.
Yeah. So we've done a lot of different ones, and thank you guys for coming. Arthritis is obviously something that we deal with quite a bit, and probably everybody in this room, or you wouldn't be here talking to us about it right now. So we're going to go through some things like what it is and risk factors, and then what can you actually do about it? Like what's out there? Because you hear all kinds of things, and we're going to talk about a few of those things. And if we don't talk about something, please ask the questions. Matt will be happy to answer them. So we'll go to this first one. So what is arthritis? So you'll hear that umbrella term quite a bit, where people will say things like it's just wear and tear, and it is wear and tear, but there's more than that. So we're gonna dive into some of the things of what it is. Some of the most common symptoms are things like pain, swelling, and stiffness, especially stiffness early in the morning, and I'll talk about that here in just a minute too. But that stiffness first thing in the morning that feels better as you move is like a hallmark sign of arthritis. We're going to talk mostly about, or all about, osteoarthritis. There are actually 3 different types, but we're going to talk about osteoarthritis, which is what we're here to discuss today. Some of the key factors that we'll get into: inflammation, body weight, and previous injuries all play a part. So it's not just wear and tear. There are lots of key factors that can go into this. So next one. So 30 million people in the U.S. have OA, or osteoarthritis. So that's a big chunk of our population, about 20% of the population. These may sound familiar: hips, knees, back. You see it in the hands a lot, right? You can see those hands, and you can see. So the most common spot for the hands, you'll have people come in and they'll think something's wrong with their wrist, and it'll be right there, right? That's one of those spots.
See it, right?
Yeah, it looks kind of like that right there. So you'll see that quite often in the thumbs and fingers, and sometimes those actually don't hurt nearly as bad as people think. They walk up to you and say, "Oh my goodness, are you okay?" And you really are. You're kind of used to it, but that thumb one seems to hurt a whole lot. There's lots of things that they can do about that. So hang on. So some of the risk factors that we're going to go over. Okay, so some of them, as you see on the left-hand side of this, are pictures.
I know, so like literally in the clinic 5 minutes ago, these pictures were perfect.
Yeah.
And we moved.
Just imagine that's the lady in the beautiful squat. She's doing a great job. Modifiable on the left, non-modifiable, or we can't change on the right. So let's talk about the modifiable things real quick. So weight actually has a lot to do with arthritis. It's a subject that nobody wants to talk about, but also that's just more pressure on your joints, right? So if you're talking about hips, knees, ankles, all of those things, especially, the more weight that's on, the more pressure is on those joints, and it's going to make those arthritis pains a little worse. Low muscle strength is another one, and you'll find those two. You'll find all 3 of these things typically go together, right? You might see a little pattern, right? So the low muscle strength is another thing that can cause a lot of issues, and where that really comes in is just taking a knee, for example, right? So there are certain muscles that help support your knee, right? In particular, it's going to be your quad and the outside of your hip. You don't think about that, but when we take a step, your quad and the outside of your hips, what's going to hold my leg straight. And if either one of those things are weak, we're going to put more stress on my knee, right? So if you come in with knee pain and you're not to the point where you're thinking about a joint replacement, those are the 2 things I'm going to go after. I'm going to show you how to strengthen those 2 things. So that's going to be where we start anyway. The other modifiable risk factors, and not always modifiable, but sometimes, diabetes, heart disease, and hypertension. And that last one may sound that's high blood pressure. That may sound a little surprising. What does that have to do with it? And to give you an example, I think all of those things kind of go together in what the doctors would call a metabolic disorder, right? So it's going to be things that have to do with the things we're eating, how much activity we have, all those kind of things, right? Those are all modifiable things that we can change to some degree anyway. Now, you may be one of those lucky people that you can't change the fact that you were born with diabetes, right? You can't change that, but the ones that come on over time, we can do things, we can make changes that will help those things. The non-modifiable, obviously, age, previous injuries. So if you've injured a joint or you've torn some cartilage in the joint, the likelihood of getting arthritis goes up. Other chronic conditions covers a lot of ground. So there are other things that can happen that maybe slow you down or cause some increased problems with your joints. Short term versus long term. I gotta make sure my slides got that order. All right, so we're gonna talk about two different things here, and Matt's gonna do most of I think all the long-term ones, maybe most of the long-term ones, but I'm gonna talk a little bit about some short-term relief, some questions that we get very often: ice versus heat. Should I take pain medications? Stretching, does that help? Modalities and what that means, we'll get into a couple of those. So that's some things that like we would do in therapy, or like a massage place might do, or a chiropractor, some things that temporarily help your pain. And then I get lots of questions about injections too. So we're going to talk about those things. So short term, heat versus ice. Question that happens a lot. So I think, and you tell me, so I'll start with this. Whatever feels better to you, you should do that if it helps you, okay? But I would tell you in general, just chronic pain and stiffness is going to respond a whole lot better to heat than it is to ice, right? Now, if it's something just happened and you're trying to numb some sort of sharp pain, the ice can benefit you temporarily, right? All these things are going to be temporary for sure. And the heat is going to be something that would help you with some of the stiffness. I've had people that have severe arthritis that they throw a heating pad on in the morning. They do some of their stretches that we've shown them, some things and get moving, and they feel better. And it takes less time to get up and get going in the morning, whereas before it was taking them a really long time to get out of bed. So the pain medication question. All right. So I am not a doctor of medicine. Okay, I'm a doctor of physical therapy. So there are some things up here that I'm going to tell you, and you can talk with your MD about them, or your pharmacist. But the commonly prescribed things for arthritis are all over here on the right. So you'll see a lot of things that fall into what we call the NSAID category, non-steroidal anti-inflammatories. Okay, so things like aspirin, Celebrex is what you see a lot, ibuprofen, so the same thing as Advil. It comes in a couple different names, but ibuprofen being the main ingredient. Naproxen, which is a leave, and diflucanide. It can be a pill or a cream. So you might have seen Voltaren gel that says for arthritis and those kind of things. I remember not too long ago when that was prescription only. Now you can buy it pretty much anywhere. I would say this: the GI issues that it can cause. This mentions that. So any long-term use of NSAIDs can cause GI disease is a risk. So that's why this isn't that short-term thing. And then also, if you have other conditions like it can affect your kidneys, and it can affect your if you're taking blood thinners, NSAIDs are a no-no, and the doctors will tell you that as well. So there's a few things you got to think about if that's the route that you're going. And again, short-term, right? People say, "Can I stretch?" And my short answer is yes. Please move. You know, the stretching itself, I'm not sure that's what's helping you, but it will feel like stretching to you. And if you think in your mind, "Hey, if I stretch, it feels better," it probably will. I think this right here, where it's talking about the synovial fluid, is probably going to be the thing that you're getting when you're stretching. So I want to tell you a little bit about that in a minute. So a movement routine of some sort, especially early in the morning, is going to be helpful, right, for short-term relief. Temporary relief of pain, and what happens when you move, people always make the joke, you know, and it makes a lot of sense when they come in, they're like, "It just feels like it needs some WD-40 in there," right? I don't know how many times I've heard that, lots and lots of times. Well, guess what? Your body makes something called synovial fluid that is the lubricant that's inside your joints. You release more of it as you move. So it's one of those things of, hey, do you know how we were talking earlier about how you feel very stiff, especially if you've been sleeping or you've been sitting for a really long time? That first little get up is like, and then you go, and then, okay, now I can walk. This is one of the reasons, right? So that synovial fluid release is one of the reasons. So the more movement you have, the better the better it's going to feel.
Shannon, do you want to say something?
Does the compression, the active compression, like the compression pants,
Yeah.
is that the synovial fluid thing, or is it just blood flow or something?
I think it's probably a little bit of blood flow and a little bit of joint support. I mean, I think it's giving you that, man, that feels nice on that joint, right? It's giving it a little bit of extra support. I don't think it's necessarily the synovial fluid.
But if that allows you to move more,
Then do it.
you get more synovial fluid.
Yeah, that's true.
So,
Yeah, it kind of goes in a
Cycle.
cycle. And I think you're a runner. I know you are. Like, compression feels nice, man. It really feels good. So, you know, is it something I'll wear all the time? No. But if it's something where you know, I know if I'm going to go out and I'm going to plant a garden, right? And I know my knee is not going to like that. I'm all for things like that in that short-term area. Now, if you wear a brace all the time, that's something we didn't address. But if you wear a brace all the time, your body's going to learn to really need that brace, right? It's going to learn to want that brace. So I'm not against them totally. I say use them when you know what, I'm going to my grandson's game and I'm going to be on my feet way longer than I usually am. I'm okay with that in that situation, but the goal would be to work out where you don't need it, right? That would be the long-term goal that we'll get to in just a little bit.
Can I ask a question?
Sure.
Yes.
What about the compression versus the break?
Like how are they different?
Like I've worn compression gloves, my husband had some, he said, here, wear these, because recently this got really inflamed.
Yeah.
It's coming a lot.
Yeah, they feel nice on your hands.
But,
for sure.
but that won't allow the joint to move.
Yeah,
I mean,
if it's restricting you to the point where you can't move, that's where I would be worried about that bracing thing that I was talking about. Let your body rely on it, but if it's something where it's like one of those copper sleeves or whatever that they sell that slide over, just a little compression and you can still move freely, I don't think you're gonna hurt yourself while wearing that.
I think it just kept that bone on.
Probably kept that thumb from moving so much, didn't it? That one hurts, according to everybody I've ever talked to. That one's bad. All right. So this is kind of a funny slide, because of how snarky the research was on it, and I'm going to be less snarky than Matt would be on it. All right, so there's some things that you can do. So ultrasound is something that's been around for a long time. Acupuncture, electrical stimulation, all of those things can help in the short term. There's not good evidence for it. We can't find research showing that it helps. It's anecdotal, like the person will say, when you did that, I felt better. Now there is some short-term relief to those, the electrical stim. I think that one has been shown for while the time that it's on. There are people that use that to get through their day. I'm not against them. Again, we're talking about short-term areas. The funniest one is ultrasound because the effectiveness, as you can see right there, so belief in the ability that it's going to work is more effective than the machine actually being turned on or not. So if that lets you know how much they think it really helps in the long term, it's not much, right? But if you think it's gonna work, there's something called the placebo effect, and it is still an effect, right? If you think it's going to help you, if you come into, and that was the other thing, if you come into things with a positive attitude, like, hey, I know I'm gonna get better at this, I know I'm gonna get stronger, you probably are. If you come into it with a negative attitude, it could be the best therapy in the world, then you might not make much of a difference, right? And that's very proven over time. But that's a funny slide. All right, what else we got?
What about infrared or laser?
all of them fall into the same thing.
Kind of the same category.
Something happens somewhere, but if you only do that, there's not gonna be a change.
I would say it to the same, basically as what Matt was saying there. If it's something you use in addition to, I think that's fine. I really do. But it's definitely not we Americans tend to want to do something that's like, hey, I'm going to pay for that thing and it's going to help me. And I just don't think that thing exists, if that makes sense. So cortisone injections. very commonly used for management of pain. You can get them about every 3 months. It's a local anesthetic, so sometimes it's a cortisone mixed with a local pain medicine at the time. I hear they hurt really bad.
I hear that.
Especially your thumb, but I've heard that they hurt really bad. Now, they can be effective, and they can be effective for some period of time.
Especially if you're trying to work.
Yes.
You're not-
There are times for it. It's deep into the joint. So these, when they first came out, they used them in the sports setting a lot. So people would get hurt on the sidelines, and they would give them the old shot and get them back in the game. And that was very destructive to young athletes. Luckily, they don't do that anymore, as far as I know. But very destructive. The things that can happen, the reason that it's every 3 months is because if you do this repeatedly, it will make the cartilage that you have go away faster. That is proven. Now, I'm not saying one is going to do that, and if it's an emergency situation, but if you repeatedly do it, it will break down the cartilage. Again, can it be something that saves you in the short term? Absolutely. Is it a long-term solution? Not a great one. They don't even do it long-term anymore. I think I got one more slide after that one, so we're gonna scoot into the, I'll talk a little bit about what actually works. The very top up there, and then I'll pass it to you. Is that all right? So go to the next slide there for me. So we'll see some evidence that the best thing that you can do for OA, osteoarthritis, is strengthening. It is actually absolutely the most effective thing that you can do with the least amount of side effects. And Matt's going to talk about that more so. What I want you to think about when we say the word strengthening, and what this slide is saying, is we associate strengthening with increased capacity. So I'm a very visual person, so for me, if I had a graph up here that showed, you've got your axes like this, and you're asking your body to do something, right? So whatever your daily tasks are, and they are going to be very different. It might be a daily task of, I need to run 20 miles, or I need to do something else, right? So you're asking your body to do something. You've got a line, you've got a capacity line of what your body will allow you to do. And when you push what you're going to do past that capacity line, it's going to hurt, right? So whether that's with arthritis or not, something is going to give away. So when we talk about strengthening, what we're really talking about is getting you to the point where your body can do what you're asking it to do. Now, again, that may be very different for different people. And that could be things like, you had that unusual day where you, normally you're on your feet for this amount of time, but you had this party to go to, and then you had this thing to do, and then you had that thing to do, and that next day you really had a bad day, right? It's, you ask your body to do something outside of that capacity zone. We need to put that line that you can do up a little bit, right? And if we can get that line up enough to where we're asking it to do something, it stays below it, you're going to be so much better off. And that's kind of what we're talking about. And I will say this too, and this is where this happens a lot, and we hear this a whole lot. This is what we're here for, is people will try to do things. They'll say, well, I tried to get active, and I had so much pain, right? I tried to get active, and that's what I did. And I am 100% not doubting that you tried to get active. You might have pushed past that capacity, right? So that's where a little bit of guidance to come in and say, hey, you know what? I know your knee's hurting, but man, that hip is weak. If we could get your hip to support that knee a little bit better, I think you'll be able to do those things that you're asking it to do. So a little bit of guidance, and for us, it's not always perfect. We're going to give you what we think is going to work, and it's not a cookbook. Like if person A and person B comes to me with the same diagnosis, and I give them the same exercises every time, they are not going to respond the same, right? So that's where, for you, we might need to work on something to get you your hip. For you, it might be your ankle, right? There's different things that we can do. So that's where some guidance of people that have been PTs for 35 years between us two comes in handy, right? So it'll be one of those things of some things that we can take.
So, can we actually manage this condition without having surgery? The short answer is it depends. So actually, any question I ask in the next 15 minutes, the answer is going to be it depends, because there's a lot of variables involved. But what we know from the latest research is that when we attack certain muscles in a level where we build the capacity and don't push that to a level where we are causing an inflammatory process or causing actual pain, that will help reduce arthritis pain overall. This first one is that targeted muscle strengthening is now becoming the first line of treatment in arthritis. Where we look at 20 years ago, the first line of treatment was whatever the newest pill came out was. To take it, get it down, and go through. That works in the short term, as Clint talked about earlier, but without changing the body at the end. See, if you look at the second part here, it says that a strengthening program of about 12 weeks that combined also some weight loss and some low activities, which basically means like aerobic activities don't push you too far into those joint areas, is probably one of the most effective treatment approaches that we have at the moment. Okay, now, these studies are focused on the quadriceps system, which is the muscle on the front, right up here in front. The stronger that muscle is, the less stress happens on the knee joint. That's very specific to that. We can correlate a little bit with, as Clint was talking, the glute muscle with the hip arthritis. And then we can correlate some of those posterior shoulders, between your shoulder blades, we can correlate those with shoulder arthritis. So utilizing these is very important in dealing with that. And this is the slide that tells us that.
Sorry, I didn't mean to.
He lets us put the slides on. That this is the one that says, if we're going to compare normal medication you get at the physician to a focused strengthening program that is dialed into your capacity level, that strengthening program is actually more effective at reducing arthritis pain in that joint if that joint will allow us to get past it. There are certain points where the capacity of the joint is just done and things have to be done. Cool. All right, so that's our strengthening section. Then we have to go into the other section. It's the one that nobody wants to talk about, as Clint said earlier. It's about weight reduction. So, the more weight we have on the system, the more chances that the load-bearing joints, hips, ankles, knees, back, will degenerate faster than the others. So in this case, it's being considered overweight or obese gives you a 5 times chance higher arthritis. Okay? So, here's a couple things. How does this actually help reduce OA? It's pretty much basically in the numbers. If we lose 1 pound of weight, that reduces 4 pounds of pressure on the knee for every 1 pound of weight. So if you're losing 5 pounds and you're right up against your capacity, that's going to increase that ability, almost 20 pounds of pressure on that knee. So sometimes something as small as that can allow somebody to have a few more years of function. And something that fat tissue does, the more just kind of metabolic fat you have around, especially the central fat, that produces significant amount of inflammatory processes. And as we learned earlier, and as we'll learn in a minute, inflammation is a big degradation. And what did we say arthritis was? It was a chronic inflammatory condition. So if we add increased fat to that, we're going to increase that inflammatory process even more. So reduced body fat percentage equals reduced inflammation overall. Now, as if we reduce weight, the cartilage in those joints is also going to reduce its degradation. It's going to stay for longer. And the longer we have cartilage, that is the buffer in between the joints that allows us to not actually make mechanical bone damage. That's where everybody talks the dreaded bone on bone. That's the actual mechanical bone damage from those muscles, those bone surfaces actually hitting. And if we can actually reduce that weight, then we reduce the rate of how the cartilage degenerates. So all these things jump on top of each other. Now, reduce inflammation. So how do we reduce inflammation? Well, why do we reduce inflammation? So pretty much, I just talked about you. The more inflammation in our body, it triggers enzymes that break down that cartilage. Okay? Inflammation where in our pain nerves actually causes pain to increase, and then that's going to actually cause structural damage. We go back 2 slides. Fat produces inflammatory compounds. So we have a larger body fat percentage, we have a higher level of inflammation in our system. Back to our chronic bone changes here. So if we have a lot of inflammation in our system, the bones actually harden and become brittle. We want our bone to be robust and spongy and able to adapt. If it's kind of brittle and hard, that's when it starts to reduce the surface ability, build up more of that reduction in the system. And then, if you have a chronic inflammatory condition, diabetes, hypertension, anything that they call a metabolic disorder, that's also going to keep you at a higher level of inflammation in your system. Okay? Those are why. Yes, Joe.
So the bone changes, like, the only reason why I know I have arthritis is every X-ray I've ever had.
Yeah.
They go, oh yeah, you got arthritis in every.
Mm-hmm.
Is it the bone changes that they're looking at, or?
They're looking at space normally.
Okay.
They're normally looking at the space between the joints that degrade your arthritis. But if you had something like a DEXA scan or something else like that, they could grade your bone changes with some osteoporosis and arthritis in that case. They're looking at both of those things.
Okay.
A lot of times it's like, hey, you come in, you have an inflamed knee joint. Hey, my knee hurts. They look at it, it's swollen. They take an x-ray. You have reduced joint space in the knee. That's going to be the main factors of us visually giving you an arthritis diagnosis. They'd really have to go, so that's kind of where that comes from. But we don't know that your knee just didn't get inflamed 2 days ago from running 5 miles, and that arthritis hasn't been there for 25 years. That's where the treatment kind of comes in to figure out where we're going. Okay? Now, moving on to the next slide here. No, that's actually a joint replacement. So, if we try to focus on those factors like we talked about in rehab, reducing weight, increasing strength, and we fail, then that's where joint replacement comes in. I mean, if you get a joint replacement after you've recovered, right, Mr. Gary? Your pain goes down really quick, right? Okay. And then your function also improves pretty quick. Well, some people would tell you it's a 15 to 25 year fix, unless what happens, Gary?
Unless your bone deteriorates.
It can't take that replacement. That's a con because sometimes that long-term fix didn't work the first time. And then you have to go through multiple surgeries to get that proper fix. And I'm assuming everybody ever been into one surgery in their life?
You say what?
One surgery in your life? Have you been through one surgery in your life?
Like on the joint?
Anything whatsoever.
Yeah.
So how do you feel after surgery? Not good for a while, right? So then you have that effect. And how do you feel after multiple surgeries? Not great either. So just the fact that you're having a surgery, they're going to put you down. Risks are a little bit more come up, and then you have a lot of, like some people can have come after surgery and like walk out of the OR feeling great, and they're like carrying their walker beside them because they just had a hip replacement, and the hip replacements are notorious for this. You just walk out of one, sometimes feel great. But some people will come out of that same hip replacement surgery and feel worse than they have in years for a good amount of time. So that's where the joint replacement is always not that perfect mecca that you're shooting for to get better. Okay, so really that's kind of what arthritis is, how we affect arthritis, and what we're going to talk about for the next maybe 10 minutes is what do we do about it, okay? So we're going to talk about prehab, which is a terminology that came into physical therapy a few years ago. So basically the purpose of pre-surgical exercise is to improve functional capacity before surgical procedure to allow more rapid post-operative recovery compared to patients who remain physically inactive during that preoperative period. So what we're talking about here is engaging in a focused exercise plan, engaging in physical therapy, engaging in some other sort of exercise prior to going into a joint replacement surgery or something like that. Why we want to do that is we usually get better faster at it. The other reason we want to do that is in certain areas we can actually improve that function so you didn't have to go into that surgery. That's our real goal coming into these prehab processes. Yeah.
Is this something new?
No. So what happens is
They didn't offer that.
there's not an so what you got to do is this is where we become advocates for ourselves. That's kind of why we're here, talking about what you can do. Okay, so your doctor might not say that. So I'm going to have surgery, and then you're like, have we talked about doing any rehab before the surgery? I don't think any of the orthopedics in town that I know would say no, because most of them will talk to you about one of the therapy before they do surgery anyway, just to try something. So that's what we want to do in this case of getting it. Here's our pretty big benefits that we see. We can reduce hospitalization stays. And that's attributed to the patient being more physically prepared and actually having clear expectations, knowing what's going on. Normally you can improve your function, muscle strength, health-related quality to actually better before, you actually be better after a good program than you were before you were going to go into that surgery. And then usually at 6 weeks for someone who's done a really good 4 week or so prehab program, usually 6 weeks after knee replacement, they're functioning higher compared to those that didn't. Okay? And actually being in better shape can also reduce pain. And if you know what's going on, you know the education, you know what your expectations are, you focus on your nutrition and your wellness before surgery, as well as getting stronger, you then have a lower complication rate. Those are the bigger factors in what we're doing. Okay, and this is Clint's slide that he likes to talk about. So talk about your mindset slide.
Oh, I kind of said this earlier. Sorry, I forgot this slide was in here.
Mm-hmm.
You know, one of the biggest things that I can see in doing what we've done for as long as we have, we've seen lots and lots of joint replacements, right? There are a lot of people that are very nervous about going into that surgery, right? It's a major surgery. They may not know how to use their walker. I've never used a walker before. What do you mean I'm going to have a walker? How am I going to do this? And how am I going to be able to get out of bed? And all these things. So not just the benefits that Matt was talking about earlier of going into it with more strength, more range of motion, and more all the things that you would think. The other part is that mental game of, hey, I'm going to be okay. He's seen this 2,000 times, you know, and they showed me I know how to walk with my walker. I know how to get in and out of that car when that can start to go home. Those kind of things are invaluable in my opinion. Of hey, you've got a little bit of mental well-being as you're going into this, thinking, hey, I'm going to be okay and I'm going to get better. I know it's going to hurt, but man, I'm going to get better after that. And one of the things I like to tell people is, you know, when you get to the point of needing a knee replacement, you'll tell the doctor it's time, right? It won't be a question of, hey,
You've had that visit with them. You're gonna tell them. I'm just gonna keep asking you every visit to go back to the doctor until you need it.
and they'll tell you when you're going to come. But sometimes just having that assurance of, I know what's going to happen afterwards. I know how this is going to go. Is a pretty big piece that I don't think everybody gets. And I wish they did. Yeah. And sometimes like you don't know until somebody like us tells you, hey, you got to be your own advocate in that situation. And sometimes they'll say, oh yeah, that's a good idea. You should go to rehab. You know.
And the other thing is,
they're not going to tell you no.
if they do,
Just come see us anyway.
you come through this anyway. Your primary care won't say no.
Yeah, your primary care will not going to know to say, hey,
One of your doctors won't say no.
one of your doctors is going to care about you.
Yeah, one of them, in your opinion, in that situation. Because I mean, we've had a lot of people in here, and that have seen us, and they've come through different avenues to get there. So really, what we're talking about, we're gonna walk away with actual one thing that you can utilize from here that will kind of help you out a little bit. So what I said was right here, I didn't get a good picture because for some reason my picture's on. We're gonna talk about just a few minutes about the deadlift, and I'm gonna tell you why it's your secret weapon against arthritis. So, what did we talk about that we need? We need to strengthen our quadriceps, we need to strengthen our glutes, and we need to strengthen our back, correct? Okay, now, how many in here have some bad knees? Bad knees. What does it hurt to do when your knees are bad? Squat. Okay? Alright. Now, anybody got some bad hips? What does it hurt to do when your hips are bad? Squat. Bend over, okay? Anybody have a bad shoulder?
Maybe.
Okay. What does it hurt to do? It's not the same answer on this one, okay? What does it hurt to do when you have a bad shoulder? Raise it up over your head, right? Okay. Now, if I was going to talk to you about targeted strengthening for the quadriceps, that's going to be a squat, right? And I'm going to talk to you about targeted strengthening for the shoulders. That's going to be an overhead press. We just talked about those things. They already hurt you. So why would we do that? There's no reason, right? But we want to get stronger. So what we want to do, Clint, come on.
You did it?
Yeah, you're ready.
I was gonna give you a box.
You're up. No, we don't do box. So, deadlift is basically a bend over pattern that doesn't squat deep enough to usually cause knee pain with arthritis. We don't jam our hip up into the position that it hurts with arthritis. And we don't put our shoulder in the position that it hurts with arthritis. But effectively managed, taught correctly, and loaded well, it hits quadriceps, glutes, and shoulder blade muscles. So it's a great way to get started with that. And we use it a lot for this. So pretty much, it's just a hinging motion that I'm going down into a position here, and I'm working myself back up. Now, most people, if they can't get to the ground, they can at least do this motion here. And what I'm working on is I'm improving my glute strength, which is going to help me reduce my chances, my intensity of my hip arthritis. Improve my quad strength, because when I'm starting out here, I'm going to straighten up, reduce my chance of my knee issues. And also my shoulder blade and upper spine strength, which is going to help me with my shoulder. Okay? That's one of the first things that we utilize with someone who has an extremely irritated arthritis. We can have them do that with the three major arthritis we see, and they're not having symptoms, but they're moving, they're stronger, and then what happens? They feel better about themselves. So we hit all those things. So that's what I kind of tell people about. This is what we're going to use first, and it's not going to be we're going to push you into your pain levels. Because once you push you into your pain levels, you'll start feeling bad about it and go into other processes. Okay? So now we appreciate your listening to us. Now, anybody else have any other questions or anything else?
Do they ever replace these joints in your?
I think they can. They're just few and far between.
Never heard of it.
And it's very difficult. And the thing is that would be done through a hand surgeon and a hand therapist. So I don't think I've ever seen a salvage joint replacement. I've seen an ankle replacement.
And one more question: do y'all ever speak on lifestyle, like diet? and
Yes,
stuff like
we do that
on
a
your-
lot in our evaluations.
The reason I ask is because this problem mine is mostly in this joint, and I was away for 2 months, and I ended up having a lot of whole milk, and
Yeah.
that's why
Yeah. so-
this one looks fine now, but
Yeah.
this one got really, really, really bad, and I recognized that was the problem.
Yeah, so a lot of times that's going to be our first setup is sleep, hydration, and nutrition
Yeah.
are your first thing that you can get done without ever setting foot anywhere and doing your first exercise.
Right.
A lot of doing well with those three things can make a difference even before you start doing anything else.
Well, thank you guys, this is very interesting.
Yeah, I know you gotta get to an appointment.
I gotta go.
Yes. Anybody else have any questions that they'd like for us to
education. So the thing, again, not a pharmacist, but they're metabolized differently, right? So, the ones that we were showing you before were all metabolized through the kidneys. I'm pretty sure acetaminophen is through the liver, so it would be different.
And then it's not an anti-inflammatory. It is a straight pain medication. There's no, so
To me, it doesn't help. Tylenol doesn't help.
And I've heard that.
I've heard that the other way,
I've heard
too.
other people say
Yeah.
that the Tylenol arthritis is the only thing that's how they sleep at night. I mean, again, it's kind of like the heat ice thing earlier.
Right.
I don't know, you tell me.
that slide of ours, where
Yeah.
we get to this guy
Yeah,
right
it's
here,
different, but
pretty much everything
similar.
on the red side, I've heard, yeah, that's good. No, that's bad. Yeah, that's good. No, that's bad. In every side, of everything on there, and including about 30 or 40 other things. Yeah, that's good. No, yeah, that's bad. Pretty much when we get to the right side, the blue side, where we're seeing the people that don't really complain about it, unless they have a really bad surgery, and those happen. You can't prevent all those.
That's a good question. That was not bad.
That's a good question. I mean,
What else you got?
it wasn't a question for pharmacists. Oh no,
I'm
Lindsay.
gonna ping pong on her question. When we're talking about nutrition, and you may have already talked about this since I wasn't in here, what foods typically make arthritis worse?
Good.
So, it would fall into the category of what we call inflammatory. So remember him talking about how the inflammatory foods are what
Those are usually things in boxes.
They're highly processed. They have a lot of sugar in them. Sorry. Remember the diabetes slide?
Or if they don't have sugar in them, they have very simple carbohydrates,
Yeah.
which basically as soon as you put it in your body, it turns to.
I think a good rule that a lot of people say is stay away from the middle of the grocery store. Shop around the outside. You get your meats, you get your protein, you get your fruits and vegetables. Think about where they are in the grocery store.
They're all on the outside.
Isn't that funny?
Yeah. Usually like people that make a big change in their appearance, they'll say they just didn't eat anything out of the box.
That's a good question.
Yeah.
The person sitting here.
Yes,
probably-
no.
We know. It was just funny.
It costs more, but.
It does cost more, but does it cost more?
Yeah.
Yeah, those are the process.
Yeah.
And the three things that he was talking about earlier, everybody, when they're talking about the training recovery thing and how I tried and it hurt, the first thing I'm going to ask you about is, are you sleeping? Are you getting enough water? Are you getting enough protein? And what dosage of exercise were you doing? What did you do? I used to walk 4 miles. I just went and walked 4 miles.
Or the question is,
Let's
my
not
knees
say-
really hurt. What did I do? I did a bunch of squats.
Yeah.
Because that's the first thing and the only thing we ever did if we have a lot of knee pain. And when did you hurt? Oh, when I squat. So we should probably not do that right now.
Let's do something else.
So let's get that knee settled down before we get that quad shot.
So Lindsay.
How much exercise should I do? If I have knee arthritis? How about that?
Exercise should I do?
As much as you can.
Yeah, the right amount.
That is the answer.
Before you start noticing that increased inflammation, so we'll find that dose for you, or you can find those things yourself. A general rule of thumb, again, this is very general, but when we were talking about walking and things, I think walking is good for a myriad of problems. Like you get on a good walking program. Don't ever go up more than 10% in a week is what I tell people. I'm like, listen, if you go out and you walk, either measure your time or your distance, and I'll make it real easy because I'm not good at math. If you can walk 10 minutes and it doesn't hurt, great. Stick at 10 minutes 3 times that week. The next week, you shouldn't go to 20. You should go to 11. Okay? And then do that. And you know what? By the end of the year, you're going to be walking as far as you ever wanted to walk. It's a slow, gradual increase. But sometimes you got to find that starting point. Everybody doesn't have to start at 10 minutes. It's just an example.
Some people may have to start at 3.
Yeah.
I'll tell people that, in your first 10-minute walk, you need to set yourself a timer for 5 minutes and go back home.
That's right. That's right. You got to make it back.
You got to make it back.
That's good.
What would be a good definition of what is inflammation? Because it sounds like everybody just considers it the boogeyman that just shows up and
Yeah.
that sort of stuff. So, I mean, is it caused by what's in your bloodstream? Is it caused by your muscle action? Or what's kind of the mechanism of action to where we say inflation? Or is it
We
pretty
say
everything?
inflammation. It's a metabolic waste product. That's exactly what it is. And if you have a poor functioning metabolic system, you have more waste product. That's a biggest thing in the central. That's like the global inflammation. But literally, if you go over and you hammer your pinky for 5 hours like this, there's going to be a actual process that the body is coming in to fix the injury that you just caused. That would be a acute inflammatory process. And that is just all the body's systems coming in and trying to fix that injury.
That's the way we heal.
That's the way we heal.
But also.
But if it stays around and it's always in, the waste products are always in the bloodstream, we never allow our normal processes, our normal systems to function again. Because they're picking up on this marker. There's more than I need in my system. So your body's gonna go back and say, why is there more of that waste in our system? We need to get that system out. When we continually go through that process, it will make us kind of have inflammation in our system all the time. That's what it is.
a really good question, man. I
It
think
was.
we probably need to change the slides next
Well,
time.
I mean,
No, that was good.
for an on-the-spot answer, I mean,
No, that was great.
you solved the mystery that I've had.
We probably need to change that to chronic versus acute inflammation, because acute inflammation is a good thing. Your body, that's how your body heals. Like chronic inflammation, not so great, right? If it hangs around for too long, it's gonna make everything around it hurt to function.
That kind of goes back to my example a minute ago when I said that you went out, last week you went to Disney with your grandkids. You walked 15,000 steps for 3 days in a row. You've not done 50,000 steps a week for the last 5 years. That is going to cause an acute injury in something. And then you're going to go to the doctor, my knee's swollen. They're going to do an x-ray, and they're going to see decreased space, and they're going to call it arthritis. We would say that you overreached your capacity, causing an acute reaction in your knee. Let's settle that capacity down. That inflammation from the knee should go away, and then you don't have that true. Now someone told you you had arthritis in your knee, and that's why you feel like your knee hurts. Now your knee hurts because you did 45,000 steps and then drove 10 hours back to Georgia and didn't move it.
I want to say something real fast too, and because I got to go treat a patient. But one thing I would say about that is don't be put in a box or locked into this because they saw something on your imaging. Okay, like we can go on and on about that, but just because you have arthritis doesn't mean that's what's causing you to hurt. Is basically what Matt's saying. You can live with arthritis. You can live with a rotator cuff tear. You can live with a hip labrum tear. They see it on the imaging. Is that what's causing your pain? Maybe. But man, I would rather try something else first before I went and got something that I didn't need, if that makes sense. There's all kinds of examples of imaging. People 65 and over, I think it's something silly like 90% have rotator cuff tears or something like that. And they don't have to have symptoms, right? Your body can adapt. So
Some sort
you're
of
powerful, man.
disease or something that people could spot. I didn't know it was just a space thing.
It's a space thing.
It's usually a space thing.
If they see if it's to the point where it's bone on bone, what they would say is it'll be wider. So like when you look at the image, it'll look more white because
Yeah,
the rub.
and you'll see some impaction in the bone.
But
And
if
there's some
they can't see it.
Oh, cool.
Yeah.
Wow, y'all changed
You
everything.
can look at that cartilage on the bottom of your knee where it's kind of flat, and you can see some like pothole dents and things in there, and that's just arthritis. Arthritis means joint inflamed.
That's all it means.
That's all it means. Wow. And osteoarthritis means bone joint inflamed.
That's right.
Okay? So really, that's all it means.
I've enjoyed it. I have to go
Yeah.
treat a patient.
Thanks,
Thank you
Mike.
very much.
Mr. Literal, you know, if you sit down and look at it, break something down. Alright. Y'all don't have any other questions? Miss Lynn, if you want to talk to Miss Lindsay or Kaylee over there, we're open to helping you guys out, but 90% of y'all are on vacation.
Living proof of pain. Oh my.